Bonjour tout le monde. Je vous laisse vous joindre là, tranquillement au webinaire aujourd'hui. Je vous invite à prendre juste un petit moment pour nous écrire, nous dire bonjour, nous dire de quelle région vous êtes et puis votre rôle, là, si vous êtes chercheur, clinicien, gestionnaire. Écrivez-nous juste pour nous dire un petit bonjour. Ça fait longtemps qu'on ne s'est pas vu. On avait arrêté notre série de webinaires là, lorsque la COVID nous a frappés au mois de mars et c'est notre premier webinaire depuis. Donc, je suis vraiment heureuse d'être avec vous aujourd'hui pour relancer notre série de webinaires. On a la chance aujourd'hui d'avoir avec nous Dr. Roland Grad. Bonjour, Roland.
Bonjour, Mélanie.
Merci d'être avec nous aujourd'hui. On va discuter aujourd'hui un peu des implications de la pandémie sur la pratique clinique et comment ça affecte la recherche, comment la recherche a joué un rôle là-dedans. Donc, un webinaire super intéressant, vraiment très pertinent. Donc, juste pour vous mentionner que vous pouvez aussi commenter le webinaire sur Twitter si vous êtes des fervents des médias sociaux. Là, vous pouvez interagir. Vous avez notre identifiant Twitter ici. Sinon, je vous présente un peu Roland. Donc, Dr. Grad est clinicien-chercheur à McGill. Il s'intéresse beaucoup au transfert de connaissances, l'utilisation de l'information par les médecins, les infirmières, les pharmaciens pour informer l'amélioration des soins et de la santé des patients. Vraiment, aujourd'hui, il va nous montrer comment ça a été vraiment important, cette utilisation d'informations-là pendant la pandémie. Donc, juste pour vous orienter un peu pour ceux qui ne sont pas familiers avec la plateforme GoToWebinar, je suis certaine que la plupart d'entre vous êtes familiers maintenant avec les plateformes de webinaire. On vit un peu en ligne, mais vous pouvez en tout temps nous écrire vos questions au fur de la présentation. Il va y avoir une période de discussion là, à la fin de la présentation. Vous pouvez aussi lever la main là, si vous souhaitez ouvrir votre micro et poser votre question de vive voix. Je mentionnerai aussi que si ça vous intéresse, les diapos sont disponibles pour téléchargement dans les documents à distribuer. Donc, vous pouvez les enregistrer là, si ça vous intéresse. Donc, Roland, peux-tu juste nous expliquer un peu comment tu t'es intéressé à ce sujet-là, comment tu as entamé là, ces travaux-là sur le rôle de la recherche là, en période de pandémie?
Mais comme médecin de famille et chercheur, c'est un peu mon travail de regarder ces choses. Et je suis aussi membre du groupe canadien, Canadian Task Force for Preventive Healthcare. Et avec des collègues, anciens collègues et des collègues comme Guylaine Thériault, qui est membre du groupe canadien, on s'intéressait dans les effets des changements en pratique clinique pendant la pandémie pour le futur des Québécois. Donc, c'est un peu comme ça.
C'est super intéressant. Puis on a vraiment hâte de vous entendre là, sur ce que vous avez trouvé. Donc, je vous inviterai à partager votre écran pour que vous puissiez mener la discussion. Entre-temps, juste mentionner à tout le monde, la présentation va avoir lieu en anglais, mais n'hésitez pas, là, vous pouvez poser vos questions en français sans problème. Là, comme vous pouvez voir, Dr. Grad, il parle très bien français, donc il va être en mesure de répondre à vos questions. Donc, Dr. Grad, je vous passe la parole pour nous partager votre présentation. Je vois votre écran.
Merci, Mélanie-Anne. En fait, je suis reconnaissant que vous me permettez de vous adresser cet après-midi en anglais. Évidemment, je peux parler anglais au travail, mais pour mes présentations académiques, certains mots sont difficiles pour moi, donc je vais changer en anglais maintenant. So as you can see, the slides are in French, and I'll just declare my conflicts of interest here. I work in Montreal as a practicing family physician, and I direct a program called the Programme du Clinicien Érudit, or Clinician Scholar Program. I'm a member of the Canadian Task Force on Preventive Healthcare, but members are volunteers. In my case, I'm paid by McGill salary for work on the Canadian Task Force and reimbursed just for meetings that are face-to-face. I also get a modest sum as a consultant for Naître et Grandir through the Fondation Chagnon in Quebec, and I get research funds from Jewel, which is a Canadian Medical Association company, for something called the POEMS, Continuing Medical Education Program. So that's my COI. Les objectifs spécifiques: comprendre la façon dont les soins cliniques en médecine de famille ont changé durant la pandémie et les conséquences de ces changements pour la recherche future. So I don't have to tell you too much about the context, but I'm going to go very quickly just through a little bit of background here. This slide has always been of interest to me. It's the ecology of healthcare. Originally, an American public health physician named Carr White published this in the New England Journal of Medicine, I think in the 1960s. And it was revisited and republished in 2001 by Larry Green and colleagues. And what we see here is that imagine you live in a hypothetical village of 1,000 persons. In any 1 month, 800 of those 1,000 people will report symptoms of some kind. About 300 will consider seeking medical care. About 200 of them will visit a physician's office. So that's this box here that I'm pointing to. And this is American, so about half would visit a primary care physician's office in the United States out of that 200. Out of those who visit a physician's office, a much smaller number, 13 down here, would visit an emergency department, and less than one person would be hospitalized in an academic medical center like the one that's attached to the clinic where I work. So this really gives you a sense of how, medical symptoms and emergency visits are represented over a population of 1,000 people in 1 month's time. So that's what we know about medical care in a pre-pandemic era in the United States, at least. I think Canada would be somewhat similar. What we also know is that the evidence to support what we do as doctors in primary care practice is not great. And this article looked at over 3,000 recommendations that are available in an online knowledge resource called Essential Evidence Plus. This is like up to date. It's what doctors use to find answers to their questions. And if of the 3,000 recommendations that they looked at, they divided them up into A, B, or C in terms of strength of recommendation. This is a taxonomy that exists to say how strong is the evidence for this intervention in terms of improving patient outcomes. And of all the recommendations they looked at, only 18% were graded A, 34% were graded B, and about half were graded C. C is basically just expert opinion, almost no evidence beyond expert opinion. So it shows you that, of all the things that we do to people in primary care, we don't have strong evidence to support much of what we do. We also know something about les soins de faible valeur. I know you had Guylaine Thériault on last year, talking about choisir avec soin, which I perhaps could come back to later because I think that's worth talking about in the context of reduced access to physicians during the pandemic. And we know that what we call low value care would be things like annual examinations and routine tests. And so what do we know about routine tests? Here's an article from JAMA Internal Medicine published just this year, actually. And some of the authors here are actually, this was done in Ontario. Some of the authors work with Choosing Wisely Canada. And what they found was that, the tests that we could do in these annual visits, things like chest x-rays, electrocardiograms, pap tests in women outside the recommended screening age from 25 to 69, all those routine tests trigger more tests. There are false positive results, there are uncertain results. These require referral, these require subsequent diagnostic tests. So it's like a cascade of intervention once you start ordering tests in people. And in practice, as a doctor, I have to deal with this all the time. For example, I had a 74-year-old woman come to my office last month and said, look, I'm going to Arizona for the winter. By the way, she's healthy. She has no active medical conditions, has no symptoms, and she's asking me for an electrocardiogram before she goes to Arizona for the winter. So part of our job in primary healthcare is to educate people as to why doing tests on asymptomatic people, that is without symptoms, can actually cause more harm than good. And this is the reality of the practice that we face. People often come in asking for tests. They've been educated and trained, in fact, in some ways over decades to come to the doctor for all sorts of things. And now we are learning that some of this is clearly of low value and should not be done. So that's just by way of background. This is all pre-pandemic, okay? Then this thing comes around. And I think it was in mid-March when we actually went into lockdown here in Quebec. And so I learned some new words. I learned some new ICD codes, Z71.1, person with feared complaint in whom no diagnosis is made. So a lot of people came to me just wanting information, but not having a diagnosis. And then, of course, COVID-19 identified, COVID-19 not identified, but suspected or probable based on other criteria. And I thought about pandemics, and here's a list of all the notable pandemics that man has gone through since the Middle Ages, starting with the Black Death in the 1300s and working up to HIV/AIDS pandemic. And I actually became a clinician in the mid-1980s in the midst of the HIV/AIDS pandemic. And the feeling, to be honest, the feeling of HIV/AIDS as it emerged in the mid-1980s when I was in my first years in practice as a doctor was very different. I mean, people were stigmatized because of who they were, what put them at risk for HIV/AIDS. We were very afraid of catching HIV/AIDS. We saw our patients as being a big threat to us. So that was the AIDS patients were a threat to us. In reality, we were more of a threat to them because they were immunosuppressed. We didn't realize that at the time. So I just mentioned that the pandemic that I lived through at the beginning of my career felt different. It wasn't a respiratory virus, of course. It was bloodborne. And it was different in who it stigmatized. So, perturbation de la pratique médicale, as I mentioned, with shutting down of the lockdown we went through, this was mid-March till about mid-June in my case, there was real disruption. I mean, we actually stopped immunizing children. We didn't see anyone in person unless it was really urgent and they had been verified to have no COVID based on a questionnaire that we would administer over the phone. So screening was shut down. I understand mammography stopped for a while. And then around a number of months later, let's say May, June, immunization started to resume. Mammography began to resume, but I would think at lower levels than before. So let's talk about the implications of all this for research. And I thought that at least conceptually it would be good to break it down into, three different aspects: biomedical, économique, and biopsychosocial. In reality, these things are overlapping, but let's just break it down like this for a moment. As far as the socioeconomic implications of what's happened here in Quebec, we know that a lot of people have been under tremendous financial strain. And this article in the BMJ talks about COVID-19, unemployment, and health, and calls for deeper solutions. Obviously, there's a link between financial stress and health. Governments are providing aid on a massive scale. The implication of this aid that we're getting from the government is that we could be facing an economic downturn in the next few years. So that's one possible problem for all of us. But what I took out as being most interesting from this article was the proposal for a universal basic income scheme that is, without no strings attached. You give $1,000 a month, for example, to all persons, all adults, and they do with it what they wish. And I wondered what would be the effect of that on the health of our communities. What would be the effect of that on homelessness? What would be the socioeconomic and health benefits of a universal basic income scheme? So that's the first question that I would raise. Then there's les conséquences sur le plan biopsychosocial. And what we're talking about here largely in healthcare workers is burnout. And speaking to my colleagues in nursing, I know that there's been a high rate of absenteeism. For example, in the operating room at the hospital where I work at, there's something like 25 nurses now on leave. When I talk to my colleague in psychiatry who does emergency psychiatry at the Douglas Hospital, she tells me they've never been busier. So the numbers of people coming in for emergency psychiatric help are extremely high. As a family doctor, I've been writing lots of notes to people who feel that they cannot go to work. I've been handing out more medication than usual. Talking about serotonin reuptake inhibitors as medication, some benzodiazepines too. So there's clearly been a stress-related effect on mental health, and that will trigger a whole bunch of research studies, I'm sure, for the next 5 to 10 years. What about the biomedical implications of changes in medical practice? Well, I was able to find a bit of data here. This comes from the British Medical Journal again. And I'm just going to try and see this. Comparing April to August of this year with the same period in 2019, the number of general practice appointments in England fell by 21%. Now, I don't know if they count telephone appointments here. I think they mean face-to-face appointments fell 21%. And it's unclear how many telephone appointments were actually done to compensate for that. And it's unclear to what extent telephone can actually compensate for face-to-face, but I believe it's a substantial, it's actually quite good. And in many cases, we can avoid in-person visits with phone calls, but of course, not all visits. And then just this past weekend, as I was flipping through something on Twitter, I came across this systematic review. This is from Ray Moynihan and colleagues in Australia. And some of you may know Ray Moynihan. He's been a leader in looking at harm and wasteful medical care and the harms associated with waste. And what he's done, and this is now only available on a preprint server, so it hasn't yet been peer reviewed, is look at the changes in the use of healthcare during the pandemic. It's a systematic review. They looked at the usual sources like PubMed, Embase, Cochrane, and even preprint servers without language restriction. And they looked until August 10th. And what they were able to find were 81 studies across 20 countries, but Canada had only one of those 81 studies, and primary care had only 9 of those 81 studies. So what we know about primary care in Canada in terms of change in use of healthcare must be very little. I don't think there's any empirical studies, but maybe I'm wrong and you'll tell me during the question period. So there are empirical studies, but they're mostly done, only 9 in primary care and only 1 in Canada. What the findings were was a median 37% reduction in healthcare services overall. This includes things like a 42% reduction in visits to the emergency department for things like abdominal pain. And so in the article, they provide a box which actually is titled Future Research. So I would encourage you guys interested in that to check it out. So some of my thoughts, before I jump there, I'll just say this is actually going to be, this article here will be presented as a webinar on November 17th. And it's, if you Google Preventing Overdiagnosis webinar, you'll be able to sign up. Unfortunately, it's on Australian time, so I think it shows up in the middle of the night here. I speculated myself on les effets de la réduction du nombre de visites en cabinet. So with screening shut down, what happens with less prescribing in primary healthcare? What happens with less monitoring of chronic conditions? So first, with regard to interruption du dépistage, I think what we will see in the next 5 years, perhaps, is that there will be two things. One is a few cases of undetected cancers will progress because we slowed down or stopped dépistage for things like breast cancer. But we will see much less overdiagnosis of cancers, so that the total number of cancers diagnosed could go down. What would be important to look at is just not the number of cancers, but treatment for cancer and mortality from cancer, because we may find that mortality from cancer did not go up, even though we did less screening. In terms of less prescribing, I mean, it's possible we could see more prescribing for people with coughs and other respiratory symptoms, but less prescribing for other types of conditions like osteoporosis if you're not testing people for that condition. And speaking of osteoporosis, if patients don't come to the office for monitoring, if they don't come for things that they're supposed to get, like in the case of osteoporosis, there's a drug called denosumab or Prolia, which is given by injection every 6 months. And it turns out that if you don't go for your injections every 6 months or so, then evidence shows that if you discontinue the drug, there's an increased risk for rebound vertebral fractures, which means that the vertebrae will fracture. Often multiple vertebrae will fracture, and this may occur as soon as 8 months after the last injection of the drug. In people who are supposed to get injections every 6 months, this could be a problem if they avoid the doctor as a result of the pandemic. I wanted to tell you briefly about my experience with COVID-19 in Montreal, because I work in Côte-des-Neiges, which is, of course, a dense urban area, and I also work attached to the Jewish General Hospital, which was a designated COVID-19 hospital in Montreal. At one point, we had about 165 patients in hospital with COVID-19. That would have been in May, I believe, and the ICU was on the verge of being overwhelmed, but we didn't quite get there, thankfully. So with the help of two colleagues, one nurse and one a medical student who was basically sent home by the university and told to wait, she had time on her hands to help me study what were the characteristics and outcomes of patients with COVID-19 who presented to our clinic. So we looked at the time period from mid-March to about May 21. And we were able to find a total of 89 patients at our clinic who met the criteria of the Center for Disease Control for COVID-19. Now, of those 89 who met criteria, 24 actually went to the emergency department because they were sick. And of the 24 who went to the emergency department, 10 were hospitalized, meaning 14 of 24 did not go to the emergency department, leaving me 14 of 24 who went to emergency did not get hospitalized. This leaves me wondering why they went to the emergency in the first place, and if it was because their family doctors were not available to guide them, to help them avoid that visit. And so in this work, which is now under review for publication as a case series, we also looked at treatment. We saw that of the 89 patients, 25 received antibiotics, mostly azithromycin. 10 of them received hydroxychloroquine or Plaquenil, and 9 received steroids, whether by oral, inhaled form, or IV. We came up with a proposal that I think could be tested in research, and it involves oximetry. So assuming you have a family doctor and a nurse as part of a groupe de médecins de famille, and they're engaged in your care and they're reachable by telephone, and you got COVID-19, I would tell you to buy a pulse oximeter, have it delivered from Amazon in 24 hours or less, and I would ask you to monitor your pulse and blood oxygen level using this oximeter, and I would follow you up at days 5 and 7 after the onset of your illness, and I would try to reassure you that you didn't need to go to the emergency. And so the effect of that intervention, having a doctor, nurse, and an oximeter to monitor you at home, I think would help to avoid a certain number of emergency visits. And this, of course, could be tested in a randomized trial. Happy to talk further with you about that down the road. Okay, with colleagues from the Canadian Task Force, including Guylaine Thériault from Gatineau, we published an article in Canadian Family Physician in August, and it was titled Rethinking Screening During and After COVID-19. We asked, should things ever be the same again? And of course, the answer is no, they should not. And so what are some of the changes that we proposed? I'm coming to that. The article was accompanied by a commentary from Christina Korownik at the University of Alberta. She basically called for a revolution, but she also called for our colleagues in family medicine to pay attention to some of the screening intervals that we pointed out in our paper. So I just want to show you that in the next few slides. Our principal messages were that vaccination needed to be maintained during the pandemic, because if you let go of vaccinating people for things like measles, you would end up with a measles outbreak at some point down the road. That you should continue screening, but only for those conditions that are strongly recommended, and I'll show you what those are. And that you should stop doing these annual examinations and do focused periodic assessments. Periodic in the sense that there's no definite time interval. It depends on your age, it depends on your sex and your comorbidities. So what are the strongly recommended conditions in terms of maintaining during the pandemic, and what intervals should these be considered at? So when we took a look at all the recommendations from the Canadian Task Force on preventive healthcare, we could basically find only 3 or 4 things. Number 1, screening for hypertension is strongly recommended every 3 to 5 years. Screening for colorectal cancer after age 60 until about age 75, every 2 years or so. And cervical cancer screening from ages 30 to 65 is strongly recommended about every 3 years. Although very interestingly, none of these so-called intervals of 3 years, 2 years, 1 year, whatever, none of these intervals has ever been subjected to a randomized trial. All of this is based on expert opinion, our knowledge of biology, and some observational studies. In fact, cervical cancer screening was never subjected to any screening trials whatsoever. So it shows you how the limits, it shows you what the limits are of our knowledge, even for things that we've been doing for many decades now. I wanted to point out another article in Canadian Family Physician, because I think it provides a framework for us to talk about the value of the things that we do as family doctors. So this is from the University of Alberta group, led again by Korownik and her colleagues. And what they tried to do was divide family medicine into 5 categories of interventions. So interventions for acute symptoms, that would be like for otitis media. Interventions for long-term conditions like la maladie pulmonaire obstructive chronique, or COPD. Primary prevention of cardiovascular disease was the 3rd category. Preventing cancer through cancer screening was the 4th category. And the 5th category was what they called health promotion, which is, I think, giving advice about things like diet and lifestyle and exercise. And if you take a doctor, take a doctor who has an average practice of about 1,500 patients, how many encounters per year will be beneficial within each of these categories. That's the second row in the table. So let's look at encounters with benefit. What you see is that you get about the same number of encounters with benefit per year, whether you're treating acute or long-term symptomatic conditions. When it comes to cancer screening, the number is exceedingly small, less than 1 encounter with benefit per year. And that's because the number needed to screen to prevent one cancer is about 1,000 for many things like colorectal cancer, breast cancer, prostate cancer. The numbers are close to about 1,000 over a 10-year period, meaning you're being screened repeatedly during that time for breast, prostate, colon. And you'll only benefit about 1 person per 1,000. So we need to keep that very small number in perspective when we look at the changes in cancer that one might detect in 2020 due to the reduced access to family doctors. But what about the harms from screening? I mean, I really like this. This is a figure chart from Ines, and it's les risques et bénéfices liés au dépistage du cancer de la prostate. And here you have a comparaison, 2 groups of men. This group is screened on the left. This group is not screened on the right. The screen group, out of 1,000 men screened repeatedly over a 13-year period, you see 5 black dots here. That represents 5 men who die out of 1,000 in the screened group. And in the unscreened group, you see 6 black dots. That's 6 men who die. By the way, this data comes from the European randomized study of screening for prostate cancer, which is the best randomized controlled trial of screening for prostate cancer that we have. What you also see is a bunch of yellow, brown, dark red, I guess, dark brown dots up here. And all of this are the harms of screening men. So out of 1,000 men screened, you'll get 140 who test positive based on a threshold of 4 for PSA. You'll get 120 of those men going for prostate biopsy, and you'll get about 30 men who are biopsied having complications from that biopsy. All of that to save 1 life. So now perhaps you understand why we recommended against screening for prostate cancer at the Canadian Task Force, because we felt the harms outweighed the benefits. So one way to look at the pandemic is, there was reduced access to doctors, but maybe that had beneficial effects. This is another similar diagram from the Canadian Task Force. By the way, the task force has all these materials in French as well. Here we are looking at breast cancer and screening 1,000 women, average risk in their 50s. Over 7 years. Why 7 years? Because that was the median time interval for screening if you looked at all the randomized trials of screening for breast cancer in the world. And basically out of 1,000 women in their 50s screened, median 7 years, follow-up, 1 life is saved. Out of all that effort, you've got 294 women with a false positive, 37 women having a biopsy that wasn't needed because the biopsy came back as benign. You've got 12 women being diagnosed with breast cancer. 8 of 12 will die anyways, despite screening. 3 will be treated for an overdiagnosed cancer, meaning a cancer that would have never caused the problem had it not been detected through the mammogram. And all of this to prevent 1 death. Not great. And one could reasonably ask, why are we screening for breast cancer? A lot of this is emotional. The why question is, why do we do this or that? It's because of risk perception. And people make decisions on an emotional basis. What they see happening to their family members, what they see happening to their friends, what they see happening on television seems to have a much bigger effect on them than numbers. So I'm in medicine because I like numbers a little bit, and numbers for me tell a story. but for many people, they have trouble with numbers. And so we try to use these diagrams for people to explain what is a complex story of harms and magnitude of harms compared to the magnitude of benefit. The problem is that we've been pushing a lot of interventions like screening for cancer for decades now. So people have been trained. And because people don't understand numbers very well, a lot of them have unrealistic expectations of the benefits and harms of treatments. And this was shown in a systematic review published in JAMA Internal Medicine by Hoffman and Delmar. The same authors actually repeated the same study, but with clinicians. And this was published just 3 years ago. And doctors are humans, and consequently, they often don't understand the magnitude of benefit that could be expected from a test and the magnitude of the harms. We work with maybe hundreds of tests in practice, in general practice, and so it's very difficult to get a clear idea of the properties of these diagnostic screening and diagnostic tests. And very often, doctors themselves don't understand how little these tests can help and how much is the potential to harm. One of the people who has tried to explain this to the world is Gilbert Welch. He is now professor at Harvard, was with Dartmouth when he did this work. And in this slide, he's trying to explain the problem of overdiagnosis. On the y-axis, you have the size of the cancer, and on the x-axis, you have time. From the first abnormal cell appearing near the 0 point to a point where the cancer becomes detectable by screening. That's that dotted vertical red line. As you can see, a very fast growing cancer just flies away like a bird before you can catch it with a screening test. Whereas other types of cancers like the rabbit, the turtle, and the snail move more slowly. And if we catch rabbits, we might actually be able to save a life. But if we catch turtles and snails, what we're catching are cancers that are overdiagnosed. That means that they would have never come to your attention, or they would have never killed you because you would have ended up dying from something else at an older age. Another way of explaining this in epidemiology is the problem of length bias. And here we're contrasting a rapidly progressive disease with a slowly progressive disease. And the vertical blue line in this case represents the time at which a screening test is applied to a population. And for rapidly progressive disease, you can see you're going to catch 2 cases, whereas for the slowly progressive disease, you're going to catch 4 cases, just because they're much easier to catch. So I'm getting closer to the end, and I thought I would sort of end off by talking about some unexpected side effects of COVID-19. This is an article published in CNN, an op-ed from Gilbert Welch, who is an internist and someone who studied the overdiagnosis problem for decades, and Vinay Prasad, who's a hematologist oncologist, and together they published this this piece in CNN, and I extracted a couple of things from that piece. First is that although some people argue that we're going to be facing an epidemic of cancer in the post-pandemic phase, I'm skeptical of that. I think it's possible that some people will actually do better because they had less medical care during the pandemic. Obviously, it's important to study mortality trends, and people are looking at that now. But are we looking at differences in terms of financial status? So, in the United States, for example, they think that medical care disruption may actually that the disruption decreases mortality among the well-off because they get less of the false positive, less of the biopsies, less of the invasive consequences of they're trying to point out that there could be a differential effect here between the rich and the poor in terms of the effects of the pandemic. Suspending cancer screening is another important area for them. They don't know if that's a good thing or a bad thing. In fact, one could see both outcomes. One could see some cancer diagnoses being missed, but one could also see many false positive tests, many biopsies, many complications of biopsies being avoided. So it's a question of harm benefit balance. And in fact, there was an interesting study published in 2008 in Norway, where they looked at the natural history of invasive breast cancer detected by screening mammography. And the bottom line of this, it was an observational study where they looked at 4 counties in Norway at the time that mammography screening was just starting in the 1990s, and they compared counties where mammography started against counties where mammography did not start. And in the counties where mammography did not start until later, they offered a one-time screening mammogram at the end of the observation period. And what they found, of course, was that there were many more cancers diagnosed in the women who lived in the counties where screening mammography was offered. But in fact, when they did the mammogram in the other group, what they call the control group, living in the counties where there was no screening mammography, the number of cancers, they just counted the number of cancers in both groups after the control group had 1 mammogram at the end, and it never caught up to the screening group. So the number of cancers was higher in the group where mammography was done repeatedly over a period of, let's say, 7 years. The implications of all that is some of the mammographically detected cancers would have spontaneously regressed on their own because they could not be detected in the control group. The same number could not be detected in the control group. So the logic of this is very interesting, and it does tell you that we are picking up cancers on mammography that would have spontaneously regressed on their own and would not have been diagnosed had we not gone looking for them. The breast cancer story and screening mammography is quite complicated, and this was an article that Welch published last year in the New England Journal of Medicine called The Epidemiologic Signatures of Canada. And in panel A, you're looking at breast cancer in women after 40, and in panel B, you're looking at prostate cancer in men after 40. And there are 2 curves. The blue one is incidence of cancer, and the red curve is mortality from that specific cancer, breast or prostate. And what you can see is in the lower figure in panel A, you can see that when they initiated mammography screening, there was a substantial rise in the incidence of breast cancer. And over the ensuing decades, there was a slow decline in mortality. That decline in mortality cannot be attributed just to screening because, of course, treatment got much better during that time period. So the decline in mortality is a combination of both improved treatment and perhaps some small benefit from screening. For prostate cancer, we see, again, a very sharp increase in the diagnosis of cancer once PSA screening is widely initiated. But then we see a drop in incidence of cancer more recently heading towards 2015. And this drop seems to coincide with recommendations from the United States Preventive Services Task Force to not screen for prostate cancer. We also see a decline in mortality, again, possibly due to the combination of better treatment and some screening. So at the end of the day, what are we going to learn from all of this? I hope that we can learn that not all of what we did in the past in primary healthcare needs to continue after the pandemic. So we actually developed a tool that we want to share in discussions with patients. We call this tool Dépister avec soin, outil de communication avec les patients qui demandent des tests fortement déconseillés. How can we talk with people who want routine electrocardiograms, routine blood tests, thyroid for this and that. So we know these tests are strongly recommended against, and we know that they're wasteful. And yet we have trouble changing behavior in clinical practice, and so we're trying, at least as a first level, to do some education, and we've developed tools to help us communicate with patients. So this tool is available on the website of the Canadian Task Force. I think there's a lot that we don't know. The uncertainty here is great, and in fact, there will be an interesting webinar next week on what we call the known unknowns. What do we know that we don't know? How can we identify these known unknowns as gaps to be addressed in future research? I mean, I'm going to quote this famous aphorism, that all models are wrong, but some are helpful. I'm not calling for more models here. I'm calling for empirical studies that would allow us to address some of the important questions. Questions like, what do we do with people who have long COVID symptoms? So just to remind you about the known unknowns, if you're interested, if you register with the BMJ, you can attend their webinar, which is happening, I think, in the next 10 days as well. At the end of the day, hopefully we'll get to a better balance between appropriate and unnecessary care. My hope is that if we reduce some of the unnecessary care that we do in family medicine, we can eventually address some of that neglected care. So I think I'll stop there, Melanie Ann, and glad to take any questions or comments.
Thank you so much, Dr. Grad. That was very, very interesting, and we certainly see kind of the breadth of information and evidence sort of emerging, but also sort of the gaps in what still needs to be known. Just as a reminder, un petit rappel pour les participants, vous pouvez nous poser vos questions par écrit, ou sinon je vous invite à lever la main là, si vous voulez poser vos questions de vive voix. Peut-être pour lancer la discussion, one question that keeps coming up again and again, Dr. Grad, is this question about the infodemic, and that providers are being, submerged by information right now. And given your expertise in sort of knowledge translation for providers, what would your recommendation be to really be able to summarize all of this emerging evidence and get it to providers so that they provide the proper care to their patients?
So that's a great question. I have done some work with the Canadian Medical Association on something called POEMs. POEMs stand for Patient-Oriented Evidence That Matters. And these are synopses that are delivered by email to members of the Canadian Medical Association. This year, because of COVID-19, they've started to do what are called COVID-19 research briefs. These are briefs, meaning 200-word synopses, with a bottom line statement. So it's sort of like a structured format. It's like, what's the clinical question being addressed in this research study on COVID-19? What's the bottom line? What type of study is this? Like, is it RCT, meta-analysis, etc.? And then there's a short 200-word synopsis. And this is pushed out on email to CMA members in the context of a popular ongoing program to which about 20,000 members of the CMA subscribe. So, you have to choose where you're drinking from, right? Like the infodemic is that metaphor of a fire hose, like, information coming at you really too much, too fast. How do you manage it? I manage it by tuning a lot of it out, to be honest. I have channels that I subscribe to, like POEMs from the CMA. I have a group of colleagues in my clinical practice who meet on Zoom, about every week or two now. Réseau-1 has tried to curate information as well, I understand. And that is another kind of trusted source. I hope it's reaching the intended audience. But there were many efforts that came at the same time. And I think that was one of the struggles, is that because so many people were calling out to you, who do you actually listen to, right?
Absolutely. And would you have any recommendations? A lot of our members are researchers who are doing sort of some of this work that you were mentioning. that needs to be done and it's ongoing, what would your recommendations be for them to be able to get the evidence out to providers in the proper channels?
So in terms of getting providers or clinicians to pay attention to research, right? That's been the knowledge translation problem. That's the quintessential KT problem. There's no silver bullet, right? There's no one magic way to do this. And key opinion leaders, it was the older 20th century way to go about it. Now with social media, people are tweeting, and med Twitter is another approach that appeals to a younger demographic. And so one thing I can tell you is that if you can align yourself with a respected organization, and the organization like the CMA is promoting what you're doing, then you are leveraging the power of that organization to be behind you, right? So having an organization that you could say, look, this message is from Dr. Smithman at Sherbrooke, but it's coming from an organization at Sherbrooke that I really know and trust, that will also help to disseminate your message. Then there's the characteristics of the message itself. It cannot contain too many numbers. So, I'm not saying it shouldn't have a mean and a confidence interval, but if you start talking about, logistic regression models and generalized estimating equations, you will tune out the audience.
That's a very good point. There's a question that's coming from your colleague, Guylaine Thériault, who is asking you, quel genre d'études pourraient être mis en place pour adresser le changement de culture nécessaire pour s'attaquer à la surutilisation des soins?
OK, juste pour vérifier si j'ai bien compris. Bonjour Guylaine. Pouvez-vous répéter la question, Mélanie-Anne?
Yeah. Quel genre d'études pourraient être mises en place pour adresser le changement de culture nécessaire pour s'attaquer à la surutilisation des soins?
So, j'ai compris changement culturel, choisir avec soin. Est-ce qu'il y a une étude qui peut être mise en place? What kind of? Je pense que la pandémie est un événement qui est plus fort que jamais. Donc, si on peut utiliser les données de la pandémie pour justifier choisir avec soin, ça serait idéal. Si on peut faire, évidemment, c'est une sorte de time series analysis. Looking at a patient important outcome. So I would imagine that we could look at the diagnosis and treatment of a certain cancer, and then try to show that even though there was less screening, there was no impact on mortality, as one example. Donc, je pense que on peut essayer de cibler un type de cancer, un intervalle de pré-pandémie, pré-post et analyse de temps. Ça serait très intéressant.
Merci, Dr. Cott. Une autre question qui nous vient d'Annick Figuère qui vous demande un peu de nous parler de comment vous avez vécu comme médecin de famille les consultations avec vos patients pendant la pandémie, quel type de questions émergeaient, comment vous vous êtes adapté?
OK, d'accord. Bonjour Annick, on se connaît. Il y a plusieurs choses qui m'ont frappé au début. Pour les personnes âgées, c'était un problème de loneliness. How do you say loneliness?
Isolation.
Isolation, oui. Oui, il y avait un problème d'isolation parce que certains de mes patients étaient locked down dans leurs appartements. Ils ne pouvaient pas sortir de leurs appartements. Et ça durait des semaines et des semaines, peut-être des mois. Donc ça, c'était au début. On parle de mois de mars, avril, mai. Par après, écoute, on a toujours resté en contact par téléphone, mais je pense que les problèmes de santé mentale sont aussi importants maintenant. En ce moment, je ressens beaucoup d'anxiété chez certains patients, des jeunes par exemple, qui veulent démarrer leur vie, qui viennent de compléter les études, mais il y a moins d'opportunités pour eux autres. Donc, je ressens l'anxiété beaucoup dans mes patients. Le mois de novembre, typiquement, est un mois difficile pour la santé mentale et la dépression aussi ressort beaucoup ce temps-ci.
Vous en avez parlé aussi un peu pendant votre présentation, là, mais est-ce que vous sentez cette même anxiété-là auprès de vos collègues en première ligne?
Est-ce que je ressens le burn-out chez mes collègues en première ligne? Non, moi, écoute, je pense que c'est plus fort pour les infirmières à l'hôpital. Parce que quand on doit faire face, when you're really confronted with COVID in front of you, ça fait peur à des gens qui ne veulent pas l'amener à la maison, évidemment, à la famille, à la maison. J'en ai vu ça, les préposés aux bénéficiaires, les infirmières qui ont tombé malades et qui ont ramené ça à la maison, j'en ai vu dans ma pratique. Heureusement, personne n'est décédé, mais ça a été très difficile pour eux autres. En médecine de famille, on est un peu protégé parce que on peut travailler par téléphone ou par vidéo. Évidemment, j'ai des obligations, je dois faire des gardes à l'hôpital face à face pour certains patients, mais il y a un dépistage, donc les patients avec COVID en théorie, ne sont pas là.
Super intéressant. Vous l'avez mentionné un peu aussi au début de votre présentation, on a vu que beaucoup des efforts de la pandémie qui nous parvenaient du ministère étaient beaucoup centrés sur les hôpitaux, sur les CHSLD, entre autres, un peu moins sur la première ligne quand même. Si vous aviez un message à faire à des décideurs ou à ceux qui organisent un peu le système de santé en lien avec votre présentation, ce serait quoi?
Mais je pense on devait trouver une façon de continuer en télémédecine. Si j'ai un message, on ne veut pas que la médecine de famille devienne la télémédecine. C'est pas ça que je veux dire. C'est que pour certains problèmes et certains patients, la téléphone, ça sert bien, ça répond bien à nos besoins et que ça devait être rémunéré.
Absolument. Je vois que notre temps est presque écoulé, donc je voulais vraiment vous remercier pour une super présentation. Les participants vous remercient aussi. Il y a plusieurs personnes qui m'écrivent pour dire que ça a été vraiment très enrichissant, très riche de vous écouter aussi sur votre expérience en première ligne. Donc, merci d'avoir partagé tout ça et d'avoir été avec nous. Si vous pouviez juste avancer à la dernière diapo, s'il vous plaît.
OK.
Donc, pour les gens qui sont avec nous, juste pour vous informer que nous aussi, on a un prochain webinaire qui est planifié au mois de décembre, donc avec Dr. Hudon, qui va nous parler de l'engagement des patients, le partenariat patient, dans une équipe pan-canadienne. Pour ceux qui ça intéresse ou qui aimeraient partager ce webinaire avec leurs collègues, le webinaire va être enregistré et mis disponible sur YouTube, donc vous allez recevoir l'information sous peu. Si ce n'est pas déjà fait, je vous invite fortement à devenir membre du Réseau 1. C'est gratuit, c'est très simple à devenir membre. Ça vous garde au courant aussi en même temps de nos prochains webinaires. Si vous avez des idées pour des webinaires, des choses que vous aimeriez qu'on couvre, n'hésitez pas à nous écrire. On est vraiment ouvert là, à organiser des webinaires pour répondre à vos besoins. Et puis, vous allez recevoir un court sondage après le webinaire pour évaluer le format, le contenu, et obtenir vos suggestions. Donc, je vous demanderai de prendre quelques minutes. Là, c'est vraiment très rapide pour nous donner votre opinion sur le webinaire. Donc, encore une fois, merci beaucoup, Dr. Grad. Merci à tout le monde et je vous souhaite une très belle fin de semaine.